Rajendra is one of the best eye surgeon known. And in fact, he's called the Terminator because he invented the Terminator chalk. And this has become so popular and managing heart cataract becomes so easy. I think he has a lot of awards to his credit and in a lot of innovator awards also. So over to you, Dr. Rajendra, for this beautiful technique.
Thank you, Dr. Vinod, for the nice introduction. And I'll share my screen. And so today I'm going to talk about yet another new technique, that is saving needle microcapsulotomy, a new technique to avoid Argentinian flag sign in introducing mature white cataract. So we have no financial interest in the subject matter of this presentation. So as you know that Argentinian flag sign is a self-propagating radial extension of the anterior capsular tear, which typically arises instantly after an initial prick with a sharp hypodermic needle or the sharp rhexis forceps. The moment you try to open up the anterior capsule with the needle or with the sharp rhexis forceps, the tear which is created by these two devices opens up and extend to the periphery and convert into the Argentinian flag sign. This phenomena was first described and reported by Daniel Perronnet in year 2000. And Daniel Perronnet actually described it to be the sequelae of raised interlenticular pressure. This was the physical principle he proposed, that it's the raised interlenticular pressure which opens up the capsule and extend to the periphery in the form of the Argentinian flag sign. Later on, the posterior to anterior compartment system was proposed by some other author, and but the concentration was on the raised interlenticular pressure only. So based on this theory, lots of newer innovations and new techniques developed to neutralize the raised interlenticular pressure. You can see here this phycocapsulotomy, precision pulse capsulotomy, punchorhexis, two-stage capsulorhexis, resilient technique, femtosecond laser-assisted opening of the creation of the rhexis in introducing cataract. So all these techniques were described, and including this small needle aspiration technique. Now, we all know that this small needle aspiration technique involves pricking the anterior capsule with a sharp 26 or 30 gauge hypodermic needle, then followed by simultaneous aspiration of the liquid lens matter to decompress the thread. But what happens actually? The moment you prick the anterior capsule, before you try to aspirate anything from the capsular bag, the capsular tears start extending. So you can see here in this video, because the moment you try to prick for the aspiration, the tear which is created with this tip of the needle starts extending to the periphery, and it converts into the Argentinian flag sign. So what literature says, we went through all literature, and literature says that it is the raised interlenticular pressure which is the basic cause for the extension of the capsular tear to the periphery. And the incidence have been reported around 3.85 to 28.3%. And what is important in the literature, what we have seen is almost 7 to 24% of the tear which extend to the periphery extend into the posterior capsule and transform into the posterior capsular tear. So which could result in a serious complication in the form of vitreous loss, lens material drop, or the capsular support loss. So this is what happens. So the anterior capsular tear should not be taken very easy, because it can convert to the posterior capsular tear and you may get into this kind of problem. So the question arises at this stage, why, despite many innovative techniques to neutralize the raised interlenticular pressure, the problem of radial extension of the capsular tear continues to be a challenge in intermittent white cataract? Why? It means it's not only the raised interlenticular pressure which is the reason for the extension of the capsular tear. There has to be some other factor responsible which assist the raised interlenticular pressure to propagate the splitting of the capsular tear after the initial prick. So we actually did an extensive retrospective examination of the surgical videos where Argentinian flag sign was noted. And what we discovered, so these were the factors which were not known till now. So what we have discovered is, first important thing, in reality, It's not the raised interlenticular pressure, the only factor responsible for the extension of the tear. We found that it is the configuration of the initial prick which is created to open up the anterior capsule by the sharp tip hypodermic needle or the rexis forceps or the cystostom. When you open up to start the capsulorhexis or to for the interlenticular fluid aspiration, when you open up the anterior capsule, that is the problem. The moment you open, the tear start extending. So it is the configuration of the anterior capsular puncture which is the most important responsibility. If you look at the video here, puncturing the anterior capsule with ultra sharp beveled hypodermic needle, it creates a small linear cut. So you can see here, because if you enter with this, you create a linear cut. And when you use the capsulorhexis forceps, we normally tear the capsule first. We tear to raise the flap. So that tear with the capsulorhexis forceps, as well as this linear cut produced by the 26 gauge needle or 27 gauge needle is the reason. So this tear, actually what happens, you have a raised interlenticular pressure, and there would be a certain volcanic eruption of the interlenticular fluid also. So these factors triggers a disruptive force along the edges of this linear cut, which we have already produced. And what happens, this linear cut easily opens up and is split along its open edges and rapidly radialized to the periphery and results into the Argentinian flaxen. So you have this split or created on the anterior capsule, which opens up because of the high interlenticular pressure. So this is the reason, like this is configuration of the initial prick, which is the most important. The second important point which we have discovered during the examination of the videos, we found that tear always extends along the radial to the initial cut. It never extends perpendicular to the cut. So it means these open edges of the radial cut is the reason, because if it were not this, then it would have extended perpendicularly also, but it never extended perpendicularly. It always extends along the linear cut of the initial prick. So henceforth, we came up with an hypothesis that if we were able to manually create an opening in the anterior capsule, which had a round and regular configuration, like a capsulotomy inclusions instead of a linear cut, we may provide resistance against the forward thrust of interlenticular pressure, thus prevent Argentinian flaxen. So we all know that if we have a round opening, that would have a much better resistance. So for this, we developed and designed a capsulotome, which is called as a saving needle capsulotome. This has a smooth, round, pointed tip, similar to saving needle system. So you can see here, this is the saving needle. The similar tip we have created for this, unlike the sharp and bevel tip of the hypodermic needle. So when this device punctures the capsule, it makes a hole of this kind, unlike the linear cut produced by the sharp hypodermic needle. So round pointed is why it is important, because the round pointed tip of the saving needle microcapsulotome, when puncture the anterior capsule, it creates a round configuration without any discontinuity. So you can see here, this is a saving needle which is puncturing the paper, and you can see that it creates a round hole. But if you puncture the capsule with the needle, it creates a cut. So it's a linear cut. So this is the problem. So round hole microcapsulotomy acts like a mini capsule. It has a much better resistance against these disruptive forces because it's round and circular. It doesn't have any open edge, so it doesn't open up easily. So you can see here in this video, like the microcapsulotomy, when you make a microcapsulotomy, because you're making a round hole on the anterior capsule. Now this round one, the moment you create the round hole, the fluid will start egressing out from the capsular bag. Now this fluid comes out from the hole which we have created on the anterior capsule. This egress of the fluid will decompress the bag. Now decompression, we can enhance the decompression by tapping and by doing a milking technique, so that you press the nucleus or periphery and then bring the fluid at the center and evacuate it from that hole. So this hole egresses out the fluid and decompresses the bag. Once your bag is decompressed, then you can very easily start the capsulorhexis without any risk. of extension. These are some of the videos. So you can see the first video. I'm showing you how it makes, because this is an immature cataract, nothing to do with the intumescent cataract. But when you prick the capsule with this device, you can see here. Now see the hole. So it has created a beautiful small hole at the center. So this device creates a hole. It does not cut the capsule. Now in the second video, you can see here, when you puncture, it creates a hole. The moment you create a hole, the fluid will start egressing out of the capsular bag, and the capsular bag gets decompressed. Similarly, the third video you can see here, the moment you break it, this is the animation, and it creates a hole, and the fluid will start egressing out of the capsular bag. We generally need a single microcapsulotomy to decompress the bag. Single is enough, most of it. But sometimes you must have seen these intumescent cataracts have a multiple fluid pockets. That is not fully immature cataract. They have a multiple fluid pockets. So in these cases, we do multiple capsulotomies, multiple microcapsulotomies. But only important thing is these multiple microcapsulotomy should be done within 4.5 millimeter of the diameter. You should not go beyond 4.5 millimeter, because then since you have to make a capsulorhexis of 5 or 5.5 millimeter, the rhexis should go out of these microcapsulotomy. So you can make multiple capsulotomies to completely decompress the bag. You can watch this video. This is an absolutely intumescent cataract, swollen, white. So most important point is you have to stain the anterior capsule so that visualization is better, and then pressurize the anterior chamber. After pressurizing, then use your microcapsulotome to prick the anterior capsule. So you can see, like, we have pricked the anterior capsule. It has made a small, beautiful hole. This is the second video. Again, like, you have made a hole, and the fluid has egressed out. And now, and once you have egressed the fluid out, pressurize the anterior chamber, flatten the anterior capsule, and then you can start the capsulorhexis. You have to tear that hole now. I'm tearing that hole, making a tear from that hole, tear it, and raise a flap, and then you can start the capsulorhexis. And the capsulorhexis, you can very simply and without any risk, you can complete the capsulorhexis. So to conclude, in intumescent white cataracts, it is primarily the linear cut configuration of the initial prick made by the sharp hypodermic needle on the anterior capsule, which has the potential to spontaneously extend along its open edges, aided by the raised interlenticular pressure leading to Argentinian flag sign. The technique of sewing needle microcapsulotomy creates an opening in the anterior capsule, which has a round regular configuration, like a capsulotomy in the true sense, that provides resistance against the disruptive force triggered by the high interlenticular pressure, thus prevent the Argentinian flag sign. The simple yet very highly effective novel tool, sewing needle microcapsulotome, creates a single or multiple microcapsulotomy to adequately decompress the bag prior to initiation of the capsulorhexis. Initial decompression of the capsular bag facilitates safe and controlled creation of the capsulorhexis of desired size with higher level of efficiency and safety. Thank you very much.
Excellent.
Yeah, I would like to make a comment over here. Wonderful. I must congratulate you, Dr. RP, for thinking about this. In fact, if you look at an analogy, you will see that there is a magic trick in which a balloon is pierced by something like a knitting needle, and or this kind of the wool knitting needle. And that's a round needle again. It's a round cross-section needle. So I think this makes a lot of sense. And I guess I'll be trying that in my next case.
Yeah. The only important point is, which I want to stress here, is because you have to have the what do you call it, tilted tip, right? The tip has to go vertically.
Vertical.
And
yes.
I've done one of the case with the parallel. I went parallel also with the sewing needle, but parallel is not the ideal way to do it. You have to have the vertically, like the tip has to go vertically. Then it makes a proper hole in the capsule. So there is no risk of extension of the tear and making a tear. So you have to go vertically. That is important. And second important point is the tip has to be very sharp. The tip should not be blunt. See, actually, if you have a blunt tip, because that is what I'm seeing now in many cases, if you have a blunt tip, then it will not pierce the capsule, because many of times these capsules, they have a fibrosis and thicker at the center. So when you pierce, then it will tear if the tip is blunt. So tip has to be absolutely sharp and smooth and round. So these are the two important points which when you are using this device to prick the anterior capsule. Now, the important point is this actually technique, why I am stressing about this technique is it's very simple technique, very simple. See, you need just a saving needle, ₹1 saving needle, bend it and then prick it. Very simple, affordable, cost effective, just ₹1 device. You don't have to use that 5 crore femtosecond laser to create the capsular axis in this situation. You just use ₹1 needle to create the capsular axis. It's very simple, it's affordable, very cheap, and it's repeatable. See, it's 100% successful. So that is the most important point. And third and the last important point is, even if you don't get the prick, even if you are not able to do anything on the capsule, but you will never land up with any kind of complication because of this prick. This prick will not lead any complication. Like puncture axis, I tried puncture axis or other techniques also, because puncture axis, once I went inside and the whole lens was out of the whole lens was out. Like out means like the whole zonules were broken because with the jerk. So this kind of problem will never happen with this technique. If you are not able to puncture, just leave it. You continue with your own technique. So that is the 3-4 advantages of this technique.
Right.
I think the basic difference is with the standard needle, we get a side cut, which causes extension and since it's producing no side cuts, it's a very smooth opening inside. So its extension is not possible in this case.
So it works like a mini Rexis, we call it.
Yes.
Because we started
It's a sort of a small CCCC.
Yes.
Yeah.
And the second is, someone has suggested, instead of using phaco Rexis, you can use vitreous cutter. Vitreous cutter, I have not tried it.
So that's using vitreous cutter, using phaco tape. Why not use ₹1 needle?
Yeah, it's much cheaper.
It's so simple. And the second important thing is this puncturing the anterior capsule actually with this device. You can create a multiple puncture, because many times, as I said, you have multiple pockets. They don't get decompressed. Right. So you can create multiple puncture, which you cannot create with any other device. You can't do multiple puncture with the phaco or multiple puncture with
I agree with Rajendra. When we have a simple device, why we should go ahead with other things? Because we have tried in thousands of cases, we can manage cases easily. When we have ₹2 device, why should we go and take the unnecessary hazards?
Yeah.
Very right.
Welcome.